Welcome to As I See It. I'm your host, Dr. Jeff Kegarise. In this audio podcast series, we aim to focus on patient care, the service you should receive at any doctor's office visit, eye care education, our eyes are a precious sense, how do we protect, correct, and enhance your vision, and things that interest me, because I'm all about having fun and enjoying life. Today we want to focus on what else? Coronavirus, COVID-19. There's a lot of information out there from the media, President Trump, Governor Lee, health officials, but I want to focus on what's really happening in the trenches with providers. To that end, the next few podcasts are going to be conversations with providers, both here in our offices, the outpatient side, in the emergency room, in the hospital setting in ICU, in pediatrics, and if we can swing it, an infectious disease provider. We're speaking today with Dr. Steve Tuck, CFO and partner at Quantum HC, a hospitalist management company in Georgia. Dr. Tuck, you're on the front lines of our healthcare response. So first of all, our staff, our patients, and the community want to thank you for your efforts.
Well, I appreciate that. Needless to say, it's been a very interesting 3 or 4 weeks in the world of hospitalist medicine.
Absolutely. I'm wondering about that. Have you been overwhelmed or flooded with patients being admitted with coronavirus?
Up to now in Middle Georgia, we've been fairly fortunate. We have a number of patients that have tested positive, as well as many rule-outs. Thus far, it's been manageable. I keep getting questions from folks about how many patients are in the hospital, in the hospitals here in town, and it's been a varied situation, but it appears to be growing, but at a reasonable rate.
Okay, all right. Do you have enough bays or enough rooms for these patients?
At this point, we do. All unnecessary elective surgeries have been stopped. And interestingly, folks are not coming to the emergency room just for general care anymore, as they often will. A lot of them are just afraid they're going to get really sick, and so the emergency room's been fairly empty. Our hospital has, at this point, a 20-bed ambulatory floor connected to a 12-bed ICU. It's not full yet. They're moving in that direction. I expect sometime next week we'll open up another 23 to 25 beds on a separate floor to help accommodate the situation.
All right. Do these, when patients are admitted, for those of us that aren't in the hospital, do they automatically go to an ICU floor?
No, most patients, fortunately, most patients that we think are positive, we test them and they're ambulatory, and we send them home and ask them to isolate until the test comes back either negative or positive. The ones that are admitted, most of them are actually admitted to the floor. We have some that go directly to the ICU. Most of those have been transfers from smaller hospitals, as we have a higher level of support here. We've been very fortunate. The hospital put out a call for nurses and other staff to work these floors solely, and we had an overwhelming response from people, from the nurses, the aides, the other support staff that are dedicated to these floors until the crisis ends.
That's really tremendous. I've even seen some reports nationwide of retired physicians, NPs, PAs, nurses coming back to work to try to help out the healthcare community. Is that true down in Middle Georgia?
That has happened in other areas. We have not needed that as of yet, but it would not surprise me if that call goes out sometime in the next couple of weeks. We'll just have to wait and see.
So how do you provide, if you will, protection, safety for you as a healthcare worker and the other healthcare workers when you are caring for these people?
Well, we've been very fortunate. Our hospital, Medical Center, Donelson Health, had some great forethought, I think, in storing up supplies, buying enough PPE for us. Thus far, we have plenty of gowns, masks, shoe covers, face shields, etc. So if you are seeing a patient that is positive or is likely to be positive, on that unit, you have a 1-to-1 nursing ratio with that patient, and that nurse helps get the physician gowned up, and then decontaminates as the physician leaves the room. The protocol's been worked out pretty well, and it seems to be working very smoothly. In fact, it's actually one of the easiest places for me to practice in the hospital in the time I spent there.
Man, that sounds tremendous, because my impression is, from what I hear, that that's not necessarily the case in all hospitals across the country. Would you agree?
Yeah, I don't know. Most of the hospitalists that I have spoken with as friends from around the country in the past few weeks have not told me they have true lack of PPE. I think a lot of this is, I hope a lot of it is one-offs that the media is looking at to boost ratings, et cetera.
Mm-hmm.
If this goes on for several months, however, that could change. I know that we've got a lot of industry that are coming to the forefront to help produce more of the gowns, masks, et cetera. Hopefully the country will be able to keep up. I think it will.
Okay. Are family members allowed to be with these sick patients if they're COVID-19 positive?
No, sir. And even the suspected ones, we're not allowing the patients in. The unit is on an infrared badge entry system only. And so you have to be cleared to get in there. Not everybody is, obviously, but it works in the hospital.
Okay. And then lots of talk about hydroxychloroquine, azithromycin, anecdotal evidence that maybe it's helpful, mixed reviews, but, pretty interesting French study and all that. So are you using those in your hospital now?
We are right now. We are giving, for patients that have tested positive and are starting to deteriorate, there's a 4-day course of hydroxychloroquine and Zithromax being given. Right now, the results are fair. I think there's going to be a lot of retrospective looks at different regimens going forward, and I think a year from now we'll know a lot more about this than we do right now.
Yeah, don't you think to some degree for the lay public it gives them some level of hope to know that something's being tried or something might be helpful? And yet,
yes, and I think this is a tradition in medicine. Not everything is, half of. I was told by one of my attendings, half of everything they were teaching me was wrong. They just didn't know which half yet. And this is a souped-up version of that, if you will. I think we're learning. We're making it up every day, and there are things that are going to be tried that, in retrospect, are going to be successful. Others that are not. But the one thing to comfort most people is, I think that several months from now, when we have an antibody test before the vaccine comes out, and when many people are tested, I think you're going to find out that there was a high percentage of individuals in this country and throughout the world that got sick with COVID-19 or were infected with COVID-19 and never showed any significant symptoms from it. And that's just my opinion, but I think it's a lot more prevalent out there than we can prove right now.
Mm-hmm. Do you think that the majority of people right now that in the last month or two have had sniffles, a little bit of a runny nose, sore throat, any idea if that's because COVID-19 is rampant, or is that just kind of a typical? I mean, we run through colds, flus, and all that every season, don't we?
We do, and once again, I think only time's going to tell once we can test for it in a retrospective manner. But my best guess is that we're going to have a lot more people that were infected than ever knew it. And that's going to be great next year because those patients are going to have immunity.
Yeah. So you mentioned about using some hydroxychloroquine and Zithromax now. Who ultimately decides that in a hospital setting? Can any doctor do that? If I popped into the ER because I was running a fever and thought I was COVID positive, which I shouldn't do, I understand. I should be talking to a health professional first before I just go someplace physically, right?
Yes.
But
we try to keep folks out of the ER that may be positive because they have a chance of infecting other patients. If you're ambulatory, stay at home, take some Tylenol, drink plenty of fluids, and take care of yourself.
Okay. So, but who decides? I mean, can any doctor say, well, I'm going to start you on hydroxychloroquine and azithromycin? Or is that something that is typically decided by infectious disease or critical care? I mean, how does that all work in a hospital setting?
And normally it'll be the infectious disease doctor along with the critical care specialist. those patients, at least at our facility, and every facility is going to have different protocols, I think, through this time.
Mm-hmm.
But at our facility, if the patient starts to deteriorate, and the ID and critical care specialists feel there's no contraindications, then the patient will be placed on the chloroquine and zithromax regimen.
Okay. So we hear about at-risk patients, quote unquote, and obviously we think about people that might have cancer who are on chemo treatment and immunocompromised, or maybe the elderly. But what are some of the underlying conditions from your perspective that make you send up a red flag that say, boy, this person might be at a heightened risk in the event that they're exposed?
Any patient that has COPD, asthma, uncontrolled diabetes, end-stage renal disease, heart failure, those are the big red flags, and those are the people that we look at and say this person may deteriorate more quickly, and obviously we could keep a close eye on everybody, but those are the ones that, as you said, the red flags go up. Age is a risk factor, but the pre-existing conditions, I think, are probably going to, in the long run, turn out to be more important. Interestingly, one of my younger physicians in our practice went to our program manager and suggested that since I was close to being 60, that I probably should not be working on that floor. I informed her that I thought I was fine and that she should keep her opinions to herself.
You and I are in that same boat there. So elderly is definitely 5 or 10 years older than whatever age we are, isn't it?
Yeah. I'm kind of taking offense to the way that the media's referred to 60-year-olds.
So, okay. So you're in Middle Georgia. We're in Middle Tennessee. And at this time of year, things start to become warmer. Is that to our benefit with this virus, or is that a non-factor?
Well, I hope it is. The way we look at the contagiousness, for lack of a better term, of a virus or bacteria is conveyed through a metric that's called R naught, or it is capital R, capital 0 is the way that it is written usually. This basically refers to the average number of people that an infected person can infect in, quote, average circumstances. For example, the flu is about a 1.3 R naught, and COVID-19 we think is about 2.3 to 2.4. However, the R naught is not a stagnant number. There are a lot of factors that can play into it, such as how close people live together, ergo the situation we're seeing in New York. But one of the most common things that will adjust the R naught is temperature and humidity. For most studied infections, about when the temperature goes up 1 degree Celsius and humidity increases 1%, that'll decrease the R naught by about 0.4. So therefore, you can look at it and say, if you have an increase of Fahrenheit 18 to 20 degrees with the corresponding humidity that we get here in the South, you should decrease the COVID-19 R naught to somewhere less than 2. Now, we don't have any proof on that, but if it follows normal coronavirus activity, then that we'd see a decrease as the summer months get here.
So if I'm sitting in North Dakota and I hear this information, Dr. Tuck, should I just crank my heat to 80 inside and get a humidifier? Or is this is that not necessarily the same thing to do?
In theory, that makes a lot of sense, but it has much more to do with what happens if you are doing that. And that means you have stayed at home and you're not around the infection anyway.
Good point.
In real life, it doesn't make sense, and it'd be an interesting study sometime. But you'd have a lot of people, I think, that would need showers afterwards.
Yeah. I guess for all my friends in North Dakota, and I do have some, I guess the first more fundamental question is, why do you live in North Dakota? But that's a separate topic, so we'll discuss it.
That's a whole other discussion.
Yeah, okay. So what recommendations I know what I wanted to ask you. You had mentioned, and we talked about this issue of 6 feet. Why 6 feet? Is that a magic number? Is it just a practical distance?
That goes to the R naught that we believe that a healthy patient can be within 6 feet of a COVID positive patient for 10 minutes, as long as they're not getting coughed on and sneezed on directly. Now, interestingly, as we learn more in the past couple of weeks, the real issue may be that contaminated surfaces and the hand-to-face contact may play more of a role than actually aerosolization of the COVID-19. It's a lot of research is being done on it, but I think that's going to turn out to be a very important part of the process. But yes, in my patients that I'm with the hospital that I know are positive or highly likely positive, I do gown up completely with the face shield and all the accoutrements that go with that. However, I think as clinicians, we have to assume that every patient that we're seeing could possibly be COVID positive, and therefore we need to make sure that we try to, when we're speaking with the patient, do it at a distance that is safe for both the patient and the clinician, and also when you're examining the patient, make sure that you do it in a way that you're not directly into their face as much as possible.
Okay, so I just want to clarify something. You said that, did you say within 6 feet or outside of 6 feet?
Within 6 feet for more than 10 minutes. So for somebody that's asymptomatic, we feel like it's a safe. Now, once again, that's theory and brief experience of the past few months. It is it's something that will be tested much more in an in-depth way in the next few months.
So did you mention, or did I read somewhere, that there's a certain percent, if you had a COVID positive patient and you're within that 6 feet, and it's less than 10 minutes, was there some fact about you got a 50% chance of contracting it? Or?
We think it's less than 50%.
Okay.
And so if you are inside 6 feet for just a couple minutes doing the exam, you extrapolate it out, then maybe it's a 10 to 20% chance.
Okay. Gotcha.
I don't know how accurate that is, but that's the best guesses we have right now.
So it's both a distance as well as a time of potential exposure. Yes. Is that right?
Yes, that's what we believe.
And what I hear from you is it's not just being around people, it's the things that we normally don't even think about. I mean, I went to try to support one of my local restaurants and ordered some food curbside. I had to go in to pay, and they handed me a pen to sign my credit card. And I looked at that pen in a whole different way than I used to. Yeah. Like, where's the Purell before I touch the pen and after I touch the pen? Is that the way that a lot of viruses, it's not just coronavirus, but is that a way that we contract a lot of viruses throughout the year anyway?
Absolutely. That's why the common cold is so common.
Uh-huh.
It's you have to look at every. I think in the future we will, as a society, we will look at every surface that we didn't clean personally or didn't see cleaned as a potential risk of infection. And I think we will be hypersensitive to that over the next couple of years. And as this fades, I think we will change the way that we interact with each other and with and how frequently we wash or cleanse our hands with antibacterial lotion.
Mm-hmm.
Hopefully we will. We should do a better job of it in our society anyway, and this is going to bring it to the forefront for sure.
Yeah, it's interesting because a unique time like this causes us to reflect and reconsider what we think are our standard protocols, doesn't it? And that kind of changes what may be standard going forward.
I think it will. I think over the next year, I certainly think you'll see less people shaking hands, just as a common courtesy. I think we'll figure out other ways, whether it's a fist pump or the elbow. I think a lot of it is done jokingly now, and I think it will continue that way. But it's a heightened sense of awareness right now to hygiene. I think that's a good thing.
One of the things I'd like to be able to do is one, thank you very much for your time today, because I know you're busy, and just taking the time to help educate our community and our patients and our staff, we really, really appreciate it. But I'd like to kind of do it maybe in a couple of months and see what we have learned over a couple of months, what's changed, what's the same, what's different as we approach this COVID-19 community outbreak.
Well, we'll have a different perspective completely on it at that point. We'll know, does the heat make things better? Does more about the transmission, more about the treatments, and where we are with getting antibody testing, as well as how close we are to getting a vaccine.
You know, one thing that I know about you that the audience is about to learn, and is that Dr. Tuck, you are really an expert in many areas. Is that true? And how do you usually describe yourself to people when they say, "What?" You were waiting to do
this, weren't you?
I was waiting for this because I enjoy this so much.
Well, as you know, I have expertise in a number of things: red wine, scotch, fine cigars, prime beef, and golf in the British Isles. And I say that I know enough medicine to get by on a day-to-day basis.
Well, so maybe we will have separate podcasts on those topics in the future, because I like to talk about medicine, eye care, the business of eye care, but also things that just interest me. And you got a lot of those things that I wish I was more of an expert in. So,
you can call me anytime. I love to hear myself talk.
Listen, once again, Dr. Tuck, you are at the front lines of our healthcare response. The community thanks you. We really appreciate you, and thank you for taking the time today. Thanks, Dr. Tuck, Steve. We appreciate it.
Yeah, I appreciate it. Nice talking with you. Take care.
Now that's valuable information from the hospital side. We can always count on Dr. Tuck to speak openly and share his perspectives. If you're wondering if children can be infected by the coronavirus, listen to the next episode, where we talk with pediatrician Dr. Kelly Davis about her firsthand experience with pediatric care in the era of coronavirus in South Carolina.